Hi, my name is Lorraine Keller, and my research partner and friend is Teresa Ying, and we will be presenting to you our research study. But rather than start with the title of our study, we thought it would be more appropriate for us to start with what motivated the idea to begin with, and that is obesity. Obesity rates have quickly increased over the past few decades, and in fact, 1/3 of our American adults today are considered to be obese. That is a lot of people, and a lot of people that you will likely encounter in the operating room. With the increase of obesity, the rates of bariatric surgery have also increased. According to the American Society for Metabolic and Bariatric Surgery, since 2008, about 150,000 to 200,000 bariatric surgeries are performed on a yearly basis. So what does this mean for us as anesthesia providers? Well, first of all, this patient population, the obese patient population, poses for us a unique set of challenges. And it has a lot to do with the physiologic changes that are encountered with obesity. Most notably so being their respiratory changes that occur with the excess weight that these patients carry around. And in fact, in bariatric surgeries, respiratory complications were the most common complications encountered. On top of that, postoperative pain management is quite a challenge. These patients are extremely prone to sleep apnea and cardiopulmonary collapse if they receive high doses of opioid analgesics. So keeping this balance between achieving adequate pain relief and maintaining hemodynamic stability is quite challenging. So, how much opioids can you safely give your patients that are obese? This is a really difficult question. You want to make sure that they're comfortable, but you also want to make sure that they're ventilating appropriately and that they're oxygenating sufficiently. And in these patients, that window between keeping them comfortable and keeping their respiratory function at an optimal state has been narrowed. So answering this question is really probably not the most effective way to tackle this problem. In fact, probably the more appropriate question would be, what non-opioid analgesics can we give as adjuvants so that our bariatric patients can first of all achieve adequate pain relief while maintaining optimal respiratory function, and ideally decrease the amount of opioid analgesics they have to take in order to stay comfortable. And these were actually the questions that motivated and were the impetus behind the actual study. And I wish we could say they were our questions and they were our ideas, but they were not. Dr. Camporisi from Tampa General Hospital is an extremely well-published and well-read anesthesiologist, and the whole idea behind this project was his. So here is the title of our study, Systemic Intraoperative Lidocaine Infusion for Postoperative Pain Management in Obese Patients. This is a pilot study. I'm going to go through 3 studies as background literature to start off. First one is a systematic review of randomized control trials by McCarthy and colleagues, in which they looked over literature that had been published over abdominal surgeries, cardiac surgeries, orthopedic surgeries, and tonsillectomies using intravenous lidocaine infusions for postoperative analgesia and recovery from surgery. They looked at a total of 16 randomized control trials, which are right here. And they concluded that specifically in abdominal surgery, lidocaine infusions provided significant pain relief, reduced postoperative opioid consumption, decreased opioid-induced nausea and vomiting, promoted faster return of bowel function, and allowed for a shorter length of stay for these patients. Interestingly, these benefits were not demonstrated in the patients that underwent orthopedic surgeries, cardiac surgeries, or tonsillectomies, which was a point Dr. Camporisi had made very clear to us. He said, in some surgeries this works, but in others it hasn't, so I'm not sure if it'll work for bariatric laparoscopic surgery. The second study that I will go over is a meta-analysis by Merritt and colleagues that was published in 2008. They reviewed 8 randomized control trials, and let me start off also by saying that they only looked at abdominal surgeries. Here were their 8 studies. And they also concluded that continuous perioperative and postoperative intravenous lidocaine infusion after abdominal surgery decreased the duration of ileus, they decreased the incidence of nausea and vomiting, the severity of pain, and the length of hospital stay. The last study we'll talk about is also a meta-analysis that was published in the Canadian Journal of Anesthesia, hence why you see some of that French. We know in all, his colleagues actually looked at 29 studies. Here they are in over 4 pages. And they also found that intravenous lidocaine infusions used as an anesthesia adjuvant during general anesthesia improved postoperative analgesia in abdominal surgeries. They went on to say that they weren't comfortable making any recommendations because safety of the lidocaine infusion hadn't been systematically assessed by any study, and dosage requirements or dosage regimens had not been determined either. So I'm going to go through our study in the PICO format. So our patient population is the obese patient undergoing laparoscopic Roux-en-Y gastric bypass surgery by Dr. Moore at Tampa General Hospital. More specifically, here are exclusion and inclusion criteria. And since this is a pilot study, we had a smaller sample size than normal, 20 patients. Our intervention study, or our intervention group, had an intraoperative lidocaine infusion of running at 2 milligrams per kilogram per hour of total body weight. Our comparison group is intraoperative placebo, which is basically a dextrose infusion running at the same rate. And our outcome measurements were the visual analog scale, a safety assessment questionnaire, the analgesic requirements for the whole length of stay for the patient, the actual length of stay of the patient, and their return of bowel function. So at this point, I'm going to turn it over to my partner, Teresa, to finish out the presentation.